Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the cardiology, that is the mitral stenosis. So, mitral stenosis is one of the common valvular heart diseases. And first of all, let me tell you the basic anatomy of the mitral valve. If you see the normal mitral valve area, it is 4 to 6 centimeters square. That is a normal mitral valve area. And if you take the components of the mitral valve apparatus, the mitral valve apparatus, it contains the following components. Number one, the mitral leaflets, that is, you can see that here we have anterior and posterior mitral leaflets. And these mitral leaflets, they are placed within the mitral annulus. Okay. The second important component is the mitral annulus. So this mitral leaflets and as well as mitral annulus, right, they are connected to the chordae tendineae. Right, they are connected to the chordae tendineae. Next, followed by that, this chordae tendineae, they are attached to the papillary muscles, right. So these are the papillary muscles. So we have the anterior and as well as posterior papillary muscles. Right, and then followed by that, these papillary muscles, they are placed or they are inserted into the endocardium of the heart. So these constitutes the mitral valve apparatus, mainly the anterior and posterior mitral leaflets. Then we have the mitral annulus, then chordae tendineae and as well as the papillary muscles. Now, so area of the mitral orifice in adults is 6 to 8 centimeter square, 0.5 to 2 centimeter square, 4 to 6 centimeter square, 1 to 4 centimeter square. So the area of mitral orifice in adults, it is 4 to 6 centimeter square. Now, if you take the mitral stenosis, see, we classify the mitral stenosis depending upon the valve area. Normal mitral valve area, it is around 4 to 6 centimeter square. And if you take mild mitral stenosis, right, mild mitral valve stenosis, the area will be around 1.5 to 2 centimeter square. Right, the area will be around 1.5 to 2 centimeter square. Whereas, if you take the, after mild, we have again the moderate mitral stenosis. So, moderate mitral stenosis, the valve area is 1 to 1.5 centimeter square. That will be moderate mitral stenosis. Then followed by that, if you see the severe mitral stenosis, the severe mitral stenosis, it is less than 1 centimeter square. Okay, that will be the severe mitral stenosis. Then if you see the critical mitral stenosis, the critical mitral stenosis will be less than 0.8 centimeter square. So this is how we assess the severity of the mitral stenosis depending upon the valve area. Now after that, let me just discuss what exactly are the etiologies which will cause the mitral stenosis. So if you see the question here, a patient is admitted with pneumonia, a murmur is heard on examination, right? That is, a mid-diastolic murmur is heard on examination. Which of the following is not the etiology for mitral stenosis? So in mitral stenosis, the murmur that you will hear is the mid-diastolic murmur, okay? And you see the etiology now. The options are systemic lupus erythematosus, rheumatoid arthritis, sarcoidosis and Hurler's syndrome. See, I'll discuss the etiology in detail now, but let me tell you, among the etiologies or among the options which have been given to you, the one which will not cause mitral stenosis is the sarcoidosis. Okay, so sarcoidosis does not cause the mitral stenosis. Now, so if you see the etiology of the mitral stenosis, right? So let me tell you what is the most common cause of the mitral stenosis. The most common cause of mitral stenosis will be rheumatic heart disease. Right, it will be rheumatic heart disease. Then followed by that, the other important etiologies include severe mitral annular calcification. Right, mitral annular calcification. Then followed by that, the congenital mitral stenosis. So this congenital mitral stenosis, we call this as the parachute mitral valve. See, what is this parachute mitral valve? Let me explain you. See, parachute mitral valve in the sense, in the beginning I have shown you the image of the mitral valve apparatus. So here I have said you that we have the two chordae tendineae which are inserting onto the respective papillary muscles, anterior and posterior papillary muscle. But in case of parachute mitral valve, what will happen is you don't have, or like both of these chordae tendineae, they insert only onto the single papillary muscle. So the appearance will be in the form of a parachute. That is called as the parachute mitral valve, or that is responsible for what is called the congenital mitral stenosis. Now, apart from this, we also have the connective tissue disorders. So the connective tissue disorders that will cause mitral stenosis is systemic lupus erythematosus and as well as the rheumatoid arthritis. So these are the connective tissue diseases which will cause mitral stenosis. And we also have a storage disorder, and that particular storage disorder is mucopolysaccharidosis. Right, mucopolysaccharidosis. And what is this mucopolysaccharidosis? That will be your Hurler syndrome. Okay, so these are some of the most common etiologies which will cause the mitral stenosis. Then you take some rare causes. So if you see the rare causes of mitral stenosis, that includes number 1, left atrial myxoma. Right, this is one of the rare cause, and it actually does not cause mitral stenosis, but the scenario it stimulate, or it is similar to that of mitral stenosis. Actually, in case of left atrial myxoma, what happens is, you see here, this is the 4-chambered heart, and this is your tricuspid valve, and this is the mitral valve. So in myxoma, what happens is, from the interatrial septum, you have a tumor which is originating, and that particular tumor can overlap the mitral valve area. So once this particular tumor overlaps the mitral valve area, then the area of the mitral valve will be reduced, and that will simulate the mitral stenosis. Okay, and the next important rare cause which will cause mitral stenosis is left atrial thrombus. Right, left atrial thrombus, and then followed by that the Cor Triatrium. So I will discuss about this Cor Triatrium in detail, but these are all the etiologies which will cause mitral stenosis, and out of which the most common cause will be the rheumatic heart disease or the rheumatic fever. Then let me discuss about this storage disorder, that is Hurler syndrome. See, what is the Hurler syndrome? Hurler syndrome, it is also known as mucopolysaccharidosis. Right, it is also known as mucopolysaccharidosis, right, and it is also type 1 mucopolysaccharidosis, right. We have type 2, the other one I will tell you. Type 1 mucopolysaccharidosis, and this particular Hurler syndrome, it is classified as a lysosomal storage disorder. Now what exactly happens here, I will explain you. It is a lysosomal storage disorder. Okay, And in these individuals, basically it's a genetic disorder that results in building up of large sugar molecules, right? So there is increase in the quantity of the sugar molecules. And these sugar molecules, it includes, or they are called as the glycosaminoglycans. Glycosaminoglycans. And where are these glycosaminoglycans being stored? These glycosaminoglycans, they are stored within the lysosomes. Right, they are stored within the lysosomes. So that is the reason why it is called a lysosomal storage disorder. And see, this is a mucopolysaccharidosis type 1. We have mucopolysaccharidosis type 2 also. And this mucopolysaccharidosis type 2, it is called as the Hunter syndrome. So Hunter syndrome and as well as the Hurler syndrome, both are different. So whereas mucopolysaccharidosis type 2 is the Hunter syndrome. And this Hunter syndrome, it is an X-linked disorder. Right, it is an X-linked disorder. Whereas the Hurler syndrome, right, this Hurler syndrome, it is an autosomal recessive disorder. Right, it is an autosomal recessive disorder. So that is about the Hurler syndrome. Now you need to know what is the exact enzymatic defect in Hurler syndrome. Actually in Hurler syndrome, what is happening? There is increase in the accumulation of the sugar molecules, and that includes the glycosaminoglycans, right? And what is the enzyme defect in the Hurler syndrome? See, the underlying mechanism is deficiency of alpha L iduronidase. Right, so the enzymatic defect is alpha L alpha L iduronidase. See, this is the enzyme which is responsible for the breakdown of glycosaminoglycans. Okay, this enzyme, it causes breakdown of the glycosaminoglycans. Okay, and the enzyme replacement therapy with iduronidase may improve the pulmonary function. So what is the treatment in this individual? You need to do the enzyme replacement. And that enzyme replacement is done with iduronidase. Right, it is done with iduronidase. So when the enzyme replacement is done with iduronidase, that will improve the pulmonary function. Right, that will improve the pulmonary function. So that is about the enzyme defect in the Hurler syndrome. Okay, now after having discussed about the Hurler syndrome, which is one of the etiology causing mitral stenosis, let me discuss about the Cor Triatrium, which will simulate the mitral stenosis. See, Cor Triatrium, you know, this is one of the very rare form of the congenital heart disease. Right, it is one of the rare form of it is one of the rare form of the congenital heart disease. So it is just present in 0.1% of population. Now in these individuals with Cor Triatrium, what exactly happens? Like what exactly is the abnormality? See, it is characterized by draining of part of or all of the pulmonary veins into the accessory chamber that is linked to the distal portion of the left atrium. See, you can observe here, we have, right here we have one chamber in the other chamber, and this will be your right atrium. So left atrium, it is divided into two portions. So what is that two portions? How is it divided? See, this particular structure, whatever is there, it is nothing but it is a fibrous band. Right? It is a fibrous band which separates the left atrium into two chambers. So in this Cor Triatrium, what is happening? There will be draining of a part of or all the pulmonary veins into the accessory chamber. You see, this is the accessory chamber. Right, this is the accessory chamber. Into this accessory chamber, a part of the pulmonary veins or all the pulmonary veins, they open into the accessory chamber. And this particular accessory chamber, right, this particular accessory chamber, it is connected to or linked to the distal portion of the left atrium, right? And this disease presents in infancy and it is rarely seen in adults, okay? So it is present in infancy and it is rarely seen in adults, okay? And this Cor Triatrium, radiographically, hemodynamically and clinically, it resembles the mitral stenosis, but let me tell you, it does not represent the true valvular mitral stenosis, okay? So it is not a true right, it is not a true valvular mitral stenosis. So this is about your Cor Triatrium. So Cor Triatrium, it is a very rare form of congenital heart disease characterized by draining of a part of or all of the pulmonary veins into the accessory chamber that is linked to the distal portion of the left atrium. And the disease present in infancy and it is rarely seen in adults. And this Cor Triatrium radiographically, hemodynamically and clinically resembles mitral stenosis but does not represent the true valvular mitral stenosis. Now, coming to the hemodynamics of the mitral stenosis. Right, coming to the hemodynamics of mitral stenosis. See, in the normal condition, the mitral valve opens during the ventricular diastole. So, the mitral valve, it opens into the left ventricle during the left ventricular diastole, and thereby it allows the flow of blood from the left atrium to the left ventricle. So during the left ventricular diastole, the blood it flows from left atrium, right, from left atrium to the left ventricle. And at this time, the ventricle is in the relaxation phase, right? When the blood is moving from left atrium to the left ventricle, ventricle is in the relaxation phase. So, the pressure of the left ventricle is less than the pressure of the left atrium. So, during diastole, you have to know that the pressure in the left ventricle it is less than left atrium, right? Pressure in the left ventricle, it is less than left atrium. Thus, the blood flow from left atrium to the left ventricle, because the pressure in the left ventricle is less than compared to that of the left atrium, thus allowing the blood flow from the left atrium to the left ventricle. Now, in case of mitral stenosis, what will happen? See, whatever I have explained you is the normal event, normal physiology in a normal individual. But in case of mitral stenosis, the valve does not open completely. So, in case of mitral stenosis, right? In case of mitral stenosis, valve does not open completely. So the left atrium has to generate some extra pressure to push the blood through the stenosed mitral valve. So here in this case, left atrium, it has to generate some extra pressure okay, it has to generate some extra pressure to push the blood from the left atrium to the left ventricle through the stenosed mitral valve. So what will happen to the pressure in the left atrium now? The pressure in the left atrium is increased. Now for suppose you take in case of severe mitral stenosis. So what do you understand by this word severe mitral stenosis? Where the valve area is less than 1 centimeter square. Okay, so when the mitral valve area becomes less than 1 centimeter square, there will be tremendous increase in the left atrial pressure. Okay, there is tremendous increase in there is tremendous increase in the left atrial pressure to push the blood through the stenosed mitral valve. Okay, so thereby, to push the blood through stenosed mitral valve. So you take the normal left atrial pressure. How much will be the normal left atrial pressure? The normal left atrial pressure, it will be around 5 millimeters of mercury. Right, the normal left atrial pressure will be around 5 millimeters of mercury. But in case of the severe mitral stenosis, the left atrial pressure increases to 25 millimeters of mercury. Right, but in case of severe mitral stenosis, the left atrial pressure increases to 25 millimeters of mercury to maintain the normal cardiac output. So now in this pressure what will happen? So the left atrial pressure is almost 5 times it is increased. So that increased left atrial pressure will be reflecting back onto the pulmonary veins. So you have to remember that pulmonary veins, they have no valves, and these pulmonary veins, these pulmonary veins, they have no valves. They have no valves. So the pressure within the left atrium, whenever it is increased, the blood from the left atrium will enter into the pulmonary vein. The blood from the left atrium will enter into the pulmonary vein. Okay, because the pulmonary vein has no valve. You understand that? So, and subsequently what will happen? The pressure from the left atrium will be transmitted to the pulmonary vein, from the pulmonary vein to the pulmonary capillaries. So this pressure, this pressure, it is being transmitted into the pulmonary veins, or it has been transmitted into the pulmonary veins. Okay, so subsequently what will happen now? So there will be pulmonary capillary engorgement. So there will be increase in pulmonary venous pressure. Subsequently, there will be increase in the pulmonary capillary wedge pressure, and that will cause pulmonary capillary engorgement. That will cause the pulmonary capillary engorgement, and subsequently that will lead to the development of pulmonary congestion. right? That will lead to pulmonary congestion, and which eventually causes the pulmonary hypertension, right? Which eventually causes the pulmonary hypertension, right? And due to pulmonary hypertension, you know what happens? There is compensatory hypertrophy of the right ventricle. So basically, there will be, whenever there is pulmonary hypertension, there will be increased afterload onto the right ventricle, and thereby there will be right ventricular hypertrophy. So that is about the hemodynamics of the mitral stenosis. Let me just summarize all the hemodynamics. So in patients with mitral stenosis, there will be obstruction to the flow of blood across the mitral valve during diastole. Thereby, there will be a mid-diastolic murmur. And because of the obstruction, there is decrease in blood flow across the mitral valve. Now what the left atrium will try to do? Left atrium tries to compensate for this obstruction by increasing its pressure. You see here, there will be increase in its pressure. And this increase in the left atrial pressure results in the left atrial hypertrophy. Right? It results in left atrial hypertrophy. And because of this left atrial hypertrophy, the left atrium has limited capacity for hypertrophy. So what will happen to your LA volume? The LA volume will be reduced. Okay. So as the LA volume is reduced, what will happen to your LA pressure then? LA pressure is increased. Right? The left atrial pressure is increased. So with very high pressure which is generated within the left atrium, the stenosed mitral valve will open during diastole of the ventricle, and that will give rise to a sound that is called opening snap. So here in mitral stenosis, the mitral valve opens, right? It opens the mitral valve with force, right? Opens the mitral valve with force, and thereby the individual will have the opening snap. Okay. Now the another point is, there is absence of the valve between the left atrium and pulmonary veins, right? So that pressure whichever is increased within the left atrium will be transmitted into the pulmonary veins, right? Will be transmitted to the pulmonary veins. So thereby what will happen to your pulmonary venous pressure? Increases, and subsequently there will be pulmonary capillary engorgement and pulmonary congestion, and subsequently there will be increase in the pulmonary arterial pressure. Right, subsequently there will be increase in pulmonary arterial pressure. So once the pulmonary arterial pressure increases, there will be increased afterload onto the right ventricle, right? So there will be development of pulmonary hypertension, and there will be compensatory hypertrophy of right ventricle in response to your pulmonary hypertension. So this will be the hemodynamics in patients with the mitral stenosis. Now, after having discussed about the hemodynamics, let me discuss the clinical features in patients with the mitral stenosis. So if you see the clinical features in mitral stenosis, in case of mild to moderate mitral stenosis, the two important clinical syndrome classically occur in patients with mitral stenosis. That is, in case of mild to moderate mitral stenosis, the left atrial pressure and cardiac output may be essentially normal, right? So they are not increased much, the left atrial pressure and as well as the cardiac output, both of them, they may be essentially normal, and the patient is either asymptomatic or symptomatic only with extreme exertion. Okay, so here the patient is either asymptomatic right, or the individual may be symptomatic right, may be symptomatic on extreme exertion. And the measured valve area in case of the mild to moderate mitral stenosis, in case of mild it is around 1.5 to 2 centimeters square, whereas in moderate mitral stenosis, it is 1 to 1.5 centimeters square. Okay, so this is the valve area. This is the valve area. So in mild to moderate, either the individual is asymptomatic or the individual might be symptomatic only with extreme exertion. And what will be the symptoms? That will be in the form of the dyspnea, right? And that will be in the form of fatigue. So why is that the individual can have the dyspnea? That is because of the development of the interstitial edema and as well as the alveolar edema. And why is that they will have fatigue? That is because of decrease in the cardiac output, right? That is because of decrease in the cardiac output. And apart from the dyspnea, rarely or few patients, they can also have cough. But again, if you take the cough, if it is just only interstitial edema, the individual will have dry cough. But if it is like alveolar edema, the individual will have cough with expectoration. Okay, next you see in patients with severe mitral stenosis. In severe mitral stenosis, the valve area will be less than 1 centimeter square. Right, valve area will be less than 1 centimeter square. So these patients, they develop severe pulmonary hypertension. Right, these patients, they develop severe pulmonary hypertension. And why is that? That is due to or secondary to severe mitral stenosis. So in this condition with the severe mitral stenosis, the pulmonary edema is uncommon. So pulmonary edema right, the pulmonary edema, it is uncommon in severe mitral stenosis. So you have to understand that once the pulmonary hypertension develops, right, once the pulmonary hypertension develops, the chances of development of the pulmonary edema is less, right, because once the pulmonary hypertension develops, there will be right ventricular hypertrophy and there will be right heart failure. Okay, so the chances of development of pulmonary edema is uncommon. But what will be the features? These individuals, they will have symptoms of low cardiac output. Right, symptoms of low cardiac output. And what will be that symptoms of low cardiac output? That will be fatigue. Right, and what will be the symptoms of low cardiac output? That will be fatigue. And these individuals will also have the symptoms of right heart failure. Right, they also have the features of right heart failure. And this particular features of the right heart failure, it includes raised JVP, tender hepatomegaly, and there will be also development of the pedal edema. Now, apart from that, these individuals, they also develop the atrial fibrillation. Okay, so that is paroxysmal or chronic atrial fibrillation eventually develops in 50 to 80% of patients. Right, so this paroxysmal or chronic atrial fibrillation, it eventually develops in 50 to 80% of patients. So, right, so any increase in the heart rate, it reduces the diastolic filling. See, actually what will happen in the atrial fibrillation? In atrial fibrillation, the heart rate increases. Okay, so any increase in the heart rate, it reduces the diastolic filling time. So in atrial fibrillation, there is increase in the heart rate. So once there is increase in the heart rate, that will reduce right, that will reduce the diastolic filling time and increases the mitral gradient. So once the diastolic filling time is decreased, so the quantity of the blood which is moving from left atrium to the left ventricle will be reduced in patients with the atrial fibrillation, and thereby there will be increase in the mitral gradient. So, and it increases, so as the diastolic filling time decreases, there will be increase in right, there will be increase in the mitral gradient. Okay, so a sudden increase in heart rate, that will precipitate the pulmonary edema. So once there is increase in the mitral gradient, right, once there is increase in the mitral gradient, what will happen is there will be increase in the left atrial pressure, and that will precipitate the development of the pulmonary edema. Right, that will precipitate the development of pulmonary edema. Therefore, heart rate control is very, very important. Right, so in patients with the mitral stenosis, the heart rate control, it is very important. Okay, with slow heart rate, right, whenever the heart rate is on the slower side, with slow heart rate, you can have more diastolic filling of the left ventricle. Okay, so that is the reason why in patients with mitral stenosis, you have to ensure, or in patients with mitral stenosis with atrial fibrillation, you have to ensure that there should be a slow heart rate. Okay, and this particular slow heart rate allows more diastolic filling of the left ventricle. Right, more diastolic filling of the left ventricle. So that is about your paroxysmal or chronic atrial fibrillation. So paroxysmal or chronic atrial fibrillation eventually develops in 50 to 80% of individuals. Any increase in heart rate, right, in patients with atrial fibrillation, there will be increase in heart rate. Any increase in heart rate reduces the diastolic filling time and increases the mitral gradient. A sudden increase in heart rate may precipitate the pulmonary edema. Therefore, the heart rate control is important, with slow heart rates allowing more diastolic filling of the left ventricle. Next, on examination, what is that you will observe? On examination in patients with the mitral stenosis, you will notice again the examination findings completely depends upon the severity of the mitral stenosis. Like for suppose, we will take a scenario of severe mitral stenosis. In severe mitral stenosis, you will notice that there is development of pulmonary hypertension and there is development of right ventricular hypertrophy. So on palpation, there is left parasternal heave. Right, there will be development of the left parasternal heave. Then you take the apical impulse. The apical impulse, it will be tapping type of apical impulse. Right, and in patients with severe pulmonary hypertension, you also have the palpable P2. Right, you also have a palpable P2. So this will be the palpatory findings in patients with severe mitral stenosis. Then you take the percussion. Usually, let me tell you, if the patient is in atrial fibrillation, right, if the patient of mitral stenosis is in atrial fibrillation, right, percussion should not be done. Right, percussion should not be done. Why? Because in patients with atrial fibrillation, there is chance that there is clot of the blood within the left atrium. Okay, so once there is clot of the blood within the left atrium, there is high chance that this particular clot can shower an emboli. Right, this particular clot can shower an emboli whenever you do a percussion. So that is the reason why in patients with severe pulmonary hypertension in atrial fibrillation, no percussion. If there is no atrial fibrillation, so how can you make out whether the individual is in atrial fibrillation or not? See, when you palpate the pulse, if the pulse is irregular pulse, right, so if the pulse is irregular pulse, then these individuals will land up in, or these individuals are said to have the presence of the atrial fibrillation. So if atrial fibrillation is there, no percussion. And if atrial fibrillation is not there, then you can do the percussion. Right, if atrial fibrillation is not there, then you can do the percussion. And when you do a percussion in the pulmonary area, right, and this particular pulmonary area, it has the dull node, right? This particular pulmonary area, it has the dull node. So that is about the palpation and as well as the percussion findings in patients with the mitral stenosis. Then followed by that on auscultation. So auscultation in mitral stenosis, if you observe, see, this is your first heart sound, this is second heart sound where you have A2 and as well as P2. Then followed by that again we have the first heart sound. So between S1 and S2, it is the systolic period or systolic phase. Between S2 and S1, this will be the diastolic phase, right? And how will be your first heart sound on auscultation in patients with mitral stenosis? In most of the individuals, right, in most of the individuals, the first heart sound will be loud. Right, in most of the individuals, the first heart sound will be loud in patients with mitral stenosis. But in which scenario of mitral stenosis, the first heart sound will be soft? First heart sound will be soft in patients with calcified mitral stenosis. Right, in patients with calcified mitral stenosis, right, you will have soft S1. Then what is the scenario where you will have a variable S1? See, in patients with mitral stenosis, the first heart sound may be variable also, right? So you will have variable S1 if mitral stenosis, if it is associated with atrial fibrillation. Right, if mitral stenosis is associated with atrial fibrillation, then there will be a variable S1. So these are all the various types of the first heart sound that you will listen depending upon the scenario of the mitral stenosis. Then you take the second heart sound. Second heart sound, we have two components, A2 and as well as the P2, right? So if the individual develops pulmonary hypertension, then the P2, it will be loud, right? P2 will be loud, okay? So when does your second heart sound occurs? Second heart sound occurs during protodiastole or during the isovolumetric relaxation phase. Now after S2 is what? It is due to closure of your aortic and as well as the pulmonary valve. So once the aortic and pulmonary valve closes, that is the point when the mitral valve and as well as tricuspid valve opens. And what did I tell you in the hemodynamics? The pressure within the left atrium is very high. So that increased pressure within the left atrium will open the stenosed valve with a greater pressure, right? Will open the stenosed valve with a greater pressure. So once that increased pressure in the left atrium opens the mitral valve with greater force, that will make you to listen an additional sound, that is opening snap, right? That will make you to listen an additional sound, that is called opening snap. And this opening snap, let me tell you, it is a diastolic sound. Now after the opening snap, the blood from the left atrium will try to move to the left ventricle, and the large quantity of the blood from left atrium will move to the left ventricle during the mid part of the diastole. So a turbulence is created across the obstructed mitral valve, and that will result in the auscultation of mid-diastolic murmur, right? That will result in the auscultation of a mid-diastolic murmur. And this mid-diastolic murmur, it is a low-pitched sound, right? It is a low-pitched sound. And this mid-diastolic murmur, it is heard at the apex of the heart, right? It is heard at the apex of the heart. Then in the later part of the diastole, you have one more additional sound, okay? And this one more additional sound, it is a pre-systolic accentuation. Right, it is pre-systolic accentuation. So this pre-systolic accentuation, it is due to LA contraction. right? It is due to forcible LA contraction. See, normally when the left atrium contracts, you don't have any particular accentuation, right? The left atrium contracts and that will contribute to the second rapid filling of your ventricle. But here, the left atrium contracts very strongly. Left atrium contracts forcibly across the stenosed mitral valve, and thereby you will have an additional sound, and that will be your presystolic accentuation. So this is about the auscultation in patients with the mitral stenosis. Now, let me discuss in detail about this opening snap. So if you take this opening snap, it is a brief high pitched sound. Right, it is a brief high pitched sound, okay, and this is heard in the early part of diastole. Right, this is heard in the early part of the diastole. So this is heard after S2. Right, this is heard after S2, okay, and why is this opening snap due to? It is due to elevated left atrial pressure. This sharply opens the mitral valve during the diastole. Okay, so this elevated left atrial pressure right, it sharply opens the stenosed mitral valve. Right, it sharply opens the stenosed mitral valve, and that will result in a sound that is opening snap. And this opening snap, it occurs after S2, right? And S2, it occurs due to closure of your aortic valve and the pulmonary valve. So S2 occurs due to this closure. I mean, it is mainly during your protodiastole or isovolumetric relaxation phase. But you have to understand that after the closure of the aortic valve, right, the ventricle, it will further relax, right? The ventricle will further relax after the closure of the aortic valve. And when the ventricle is relaxing, the pressure within the ventricle drops down. And the pressure within the ventricle drops down to such an extent that the pressure within the left ventricle will be less than that of the left atrial pressure. And thereby, there will be opening of the mitral valve. So the concept is that after the closure of the aortic valve, there will be opening of the mitral valve. So that is the reason why I am saying you, after S2, you have the opening snap. So the point to emphasize is that mitral valve does not open as soon as the aortic valve is closed. There is some delay between the closure of the aortic valve and opening of the mitral valve. Okay, and you know what is that particular delay? That particular delay is required for the drop in the pressure within the left ventricle, and the pressure drop in the left ventricle should be such an extent that it should be less than that of the left atrium, and then the mitral valve opens, then the blood from left atrium will enter into the left ventricle. Okay, so opening snap, it occurs after S2. So please remember, when aortic valve closes, after a period of delay, the mitral valve opens, right? And this particular delay, it is required for the left ventricular pressure to fall less than left atrial pressure. Right, to fall less than left atrial pressure. Okay, so once the pressure within the left ventricle falls less than left atrium, then there will be opening of the mitral valve, then the blood from the left atrium will move to the left ventricle, right? So, you have to understand that opening snap, it occurs after S2. It occurs after S2. And this A2 opening snap, A2 is nothing but the closure of the valve. Okay. So, A2 opening snap, A2 is your closure of the aortic valve, and OS is opening of the mitral valve in mitral stenosis. This A2 OS gap, whatever is there, that will also decide the severity of mitral stenosis. Right, that will also decide that will also decide the severity of the mitral stenosis. Okay, so in what way it decides the severity? Let me tell you. If A2 OS gap, if it is narrowed, that tells you that the individual has, right, that tells you that the individual has severe mitral stenosis. So, the point is that the greater the proximity between the opening snap and S2, greater is the severity of mitral stenosis. Okay. So, greater is the proximity of A2 OS, greater is the greater is the severity of mitral stenosis. Okay, so that is about your A2 OS gap and their importance in the assessment of severity. I can explain you, right? You take in patients with severe mitral stenosis, that is, when the pressure becomes almost like 25 millimeters of mercury, the pressure rise within the left atrium is very high, right? The left atrial pressure is very high. So, actually, when should your mitral valve open? Mitral valve should open when the pressure within the left ventricle is less than that of your left atrium. Then the mitral valve opens, the blood from left atrium will gush into the left ventricle. That is a normal event. But in severe mitral stenosis, what is happening? The left atrial pressure is very high. So, when the ventricular pressure reduces up to 24 millimeters of mercury, at that point the mitral valve opens, the blood from the left atrium will move to the left ventricle. Whereas in a normal individual, the left atrial pressure is 5 millimeters of mercury. So in a normal individual, left ventricular pressure should go up to less than 5 millimeters of mercury. So it takes more time. And at that point, the mitral valve opens and the blood from left atrium will move to the left ventricle, resulting in the diastole. But here in severe mitral stenosis, it is not the scenario. Even the pressure within the left ventricle is reached up to 24. That is enough. The mitral valve opens, the blood from left atrium will move to the left ventricle. So that means your opening snap, it occurs earlier than normal in severe mitral stenosis. So when opening snap it is occurring earlier than normal, what will happen to your A2 OS gap? The A2 OS gap, it gets narrowed. That tells you it is the severe mitral stenosis, right? So the character of the mitral stenosis, the character of the opening snap, already we have discussed. It is sharp and high pitched sound, and it is present right, it is present in early diastole. Okay, that is about the opening snap. Now, let me discuss about the murmur. So, it is a mid-diastolic murmur. It is a low-pitched, rough, rumbling murmur. Right? It is a low-pitched, rough, rumbling murmur. That is what is the character of the mid-diastolic murmur. And where is it heard? It is heard at the apex of the heart. And is there any radiation of this murmur? There is no radiation of this particular murmur. Okay. Next. Now coming to assessment of the severity of the mitral stenosis clinically. One already I have discussed, that is the distance between the opening snap and as well as the aortic component of the second heart sound. So what did I tell you regarding this? Closer is the A to OS gap, right? Severe will be your mitral stenosis. And another important parameter which will decide the severity of the mitral stenosis is the duration of the diastolic murmur. Okay, so the severity of the mitral stenosis, it is not related to the intensity of the murmur, but it depends upon the duration of the murmur. Okay, so longer is the duration, right? Longer is the duration. Severe is your mitral stenosis, right? Intensity of the murmur does not decide the, right? Intensity of murmur does not decide the severity of mitral stenosis, right? The severity of the mitral stenosis, it is decided by the duration of the murmur. So these two parameters, one is the duration of the murmur and the other one is A to OS gap. Now, you see a clinical scenario. A previously fit 39-year-old man presents with unusual shortness of breath on exertion. At times, this is also associated with exertional palpitations. On examination, there is a loud mid-diastolic murmur, right? It's a low-pitched murmur, but it is a rough rumbling murmur at the left sternal edge. Heart rate is 122 per minute and blood pressure is normal and there is no edema. The ECG shows the atrial fibrillation. Which of the following would be the clinical findings to assess the severity in this patient? Ejection click, long gap between A2 and OS, loud S1, the long duration of mid-diastolic murmur. So, it is the long duration of the mid-diastolic murmur which will decide the severity of this disease. See, what is this clinical scenario? Suggestive of the mitral stenosis, right? And in mitral stenosis, just now we have discussed, it is narrow A2 OS gap and long duration of mid-diastolic murmur which will decide the severity of the mitral stenosis. Next, another question is, you have seen a 57-year-old woman who presents with worsening shortness of breath coupled with decreased exercise tolerance. She had rheumatic fever in her adolescence and suffers from the essential hypertension. On examination, she has signs which point to a diagnosis of the mitral stenosis. Which of the following is not a clinical sign associated with mitral stenosis? Malar flush, atrial fibrillation, pansystolic murmur which radiates to axilla, tapping, undisplaced apex beat, right ventricular heave. So, in patients with mitral stenosis, you have the presence of the malar flush. Atrial fibrillation is seen in patients with mitral stenosis, right? And tapping, undisplaced apex beat will be there in patients with mitral stenosis. And there will be right ventricular heave, and this right ventricular heave is due to right ventricular hypertrophy, right? But pansystolic murmur which radiates to the axilla, that is seen in patients with the mitral regurgitation, right? That is seen in patients with mitral regurgitation. Now, coming to the complications of mitral stenosis. One of the very important complication is the arrhythmias, and that particular arrhythmia will be the atrial fibrillation. Right, that particular arrhythmia will be atrial fibrillation. Now, apart from that, these individuals will also have the development of the hemoptysis. And this hemoptysis is due to rupture of the bronchial veins, and that will result in the development of the hemoptysis. Now, we have one more important syndrome that is called as Ortner syndrome. Right, that is called as the Ortner syndrome. See, what is this particular Ortner syndrome? It is the disorder where there is increased left atrial size, and because of this increased left atrial size, there will be compression of the recurrent laryngeal nerve. Right, there will be compression of recurrent laryngeal nerve. So, because of the compression of the recurrent laryngeal nerve, the individual can develop the hoarseness of voice. Right, the individual will develop hoarseness of voice, and that is what is called as the Ortner syndrome. Okay, and these individuals, because of increased left atrial size, they can cause the compression of the esophagus, and that will result in the development of dysphagia. So, these are the complications of mitral stenosis. And you know, this increased left atrial size can also the compression of, right, can also cause the compression of the respiratory tree, resulting in the development of V's. Right, resulting in the development of V's. So, these are the complications of the mitral stenosis. Okay, now let me discuss this Ortner syndrome. Just now I was discussing about the Ortner syndrome. It is mainly characterized by hoarseness secondary to recurrent laryngeal nerve palsy. And why is that due to? That is due to compression of enlarged left atrium. Okay, so there will be recurrent laryngeal nerve palsy. Right, there will be recurrent laryngeal nerve palsy. See, this is also referred as cardiovocal syndrome. Right, this is also called as cardiovocal syndrome. Now, what do you understand by this term cardiovocal syndrome? Cardio means there is increase in your left atrial size. Vocal, right, where there will be recurrent laryngeal nerve palsy. So, the most common cause of Ortner syndrome is the left atrial enlargement due to mitral stenosis. So, these are the complications. Now, let me discuss in detail about the atrial fibrillation. So, if you see the next question, a previously healthy 47-year-old woman with history of mitral stenosis presents with a complaint of palpitations of sudden onset. Her symptoms have been present for 12 hours. Her evaluation includes an electrocardiogram which reveals the atrial fibrillation with a ventricular response of 135 beats per minute. Her cardiac examination is unremarkable except for an irregular pulse. So, a transthoracic echocardiography is suggestive of mitral stenosis. Which of the following is the most likely classification of this patient's atrial fibrillation according to the guidelines from the American College of Cardiology? Permanent atrial fibrillation, persistent atrial fibrillation, valvular, or the lone atrial fibrillation. So, this individual is having the mitral stenosis, and this individual had a sudden onset palpitations, right, sudden onset palpitations, and these palpitations are mainly because of the atrial fibrillation. Okay, and this atrial fibrillation, it is secondary to mitral stenosis, right? And what is the etiology for this atrial fibrillation here? It is considered as the valvular mitral stenosis, right? It is considered as the valvular mitral stenosis. Okay, now according to your American College of Cardiology or American Heart Association or European Society of Cardiology guidelines, we have the following types of the atrial fibrillation. Now you take this word recurrent atrial fibrillation. Recurrent atrial fibrillation is that which occurs where the individual will have more than one episode of the atrial fibrillation. Right, where there is more than one episode of atrial fibrillation has occurred. Whereas you take this lone atrial fibrillation. Lone atrial fibrillation occurring in a patient, or lone atrial fibrillation, it is usually seen in individuals younger than 60 years. Right, younger than 60 years, who has no clinical or echocardiographic evidence of the cardiopulmonary disease. Okay, so there is no clinical or echocardiographic evidence of mitral stenosis. That is what is your lone atrial fibrillation. Okay, next, coming to the valvular atrial fibrillation. Valvular atrial fibrillation is that the individual has atrial fibrillation occurring in a patient with evidence or history of rheumatic mitral valve disease. So it occurs in individuals with evidence or history of history of rheumatic mitral valve disease, or history of rheumatic mitral valve disease, or it is seen in those individuals who have prosthetic heart valves, it is seen in those individuals with prosthetic heart valves. So that is about your valvular atrial fibrillation. We have another form of atrial fibrillation called paroxysmal atrial fibrillation. Paroxysmal atrial fibrillation is that it typically occurs or it lasts 7 days or less. Okay, so it occurs the period for which the atrial fibrillation will last is less than 7 days. Okay, and there will be spontaneous conversion to the sinus rhythm. There is spontaneous conversion to sinus rhythm. That is what is your paroxysmal atrial fibrillation. Then if you see the persistent atrial fibrillation. Persistent atrial fibrillation is that it typically lasts for longer than 7 days. Okay, whereas paroxysmal, it is less than 7 days, and there will be spontaneous conversion. Whereas persistent, it will be there longer than 7 days, and these individuals, they require pharmacological or direct current cardioversion. Okay, so these individuals, they require pharmacological or direct current cardioversion. Okay, so that is what is your persistent atrial fibrillation. Then you take the permanent atrial fibrillation. Permanent atrial fibrillation is that it is refractory to cardioversion. It is refractory to cardioversion, or that persisted for longer than 1 year. That persisted for longer than 1 year. That is what is called as the permanent atrial fibrillation. So please remember, paroxysmal, persistent and permanent atrial fibrillation categories do not apply to episodes of atrial fibrillation lasting 30 seconds or less. So that means in these paroxysmal, persistent and permanent atrial fibrillation, the episodes of atrial fibrillation will last for more than 30 seconds. And here the application of the episodes of atrial fibrillation less than 30 seconds or equal to 30 seconds will not be there. Okay, or the episodes precipitated by a reversible medical condition. So that is about your paroxysmal persistent or permanent atrial fibrillation. It will be definitely more than 30 milliseconds. Okay. Then, now what are these reversible conditions? Right, what are these reversible conditions? See, the reversible conditions include number 1, acute myocardial infarction, and number 2, cardiac surgery, number 3, pericarditis, right, number 4, myocarditis, right, and then we have the hyperthyroidism, right, then followed by that pulmonary embolism, right, and next acute pulmonary disease. Okay, so these are the conditions where the individual can develop atrial fibrillation, but these are all the reversible conditions. These are all the reversible conditions. Okay, right. So these are the types of the atrial fibrillation. Now, let me discuss what will be the treatment of the atrial fibrillation. A 69-year-old woman is admitted to the coronary care unit with unstable angina. She started on appropriate medications to reduce her cardiac risk. She is hypertensive, fasting glucose is normal and cholesterol is 159 milligrams per deciliter. She is found to be in atrial fibrillation. What is the most appropriate treatment? The options are aspirin and clopidogrel, digoxin, cardioversion, aspirin alone, warfarin. So, now whether to give antiplatelets or anticoagulants is being decided by a scoring system called as CHA2DS2 VAS scoring system, out of which the word C stands for congestive heart failure, where the individual has 1 point. The word H is the presence of the hypertension. If it is there, the individual is given a score of 1 point. And age of the individual more than or equal to 75 years, if it is there, then you need to give a score of 2 points. And if the individual is diabetic, give a score of 1 point. And if the individual has the history of stroke, then you need to give 2 points. And VAS scoring system. Vascular disease, if it is there, give a score of 1 point. Age of the individual more than 65 years, give a score of 1 point. And if the gender is a female gender, you need to give a score of 1 point. So how much will be the maximum total score? Maximum total score will be 9. So according to the guidelines, what it says is, if the score is 0, then no therapy, or you can give aspirin. Okay. For suppose, if the score is 1, then you can give aspirin or oral anticoagulant should be given. And if the score is 2, right, more than or equal to 2, these individuals, they have to be given oral anticoagulants only. Now, we will go back to our clinical scenario, what we were discussing. See, this is the clinical scenario. What is the age of the individual? Age of the individual is 69 years, right? We will give a score of 1, right? And is admitted to coronary care unit with unstable angina. That means the individual is having a vascular disease, okay? Right? The individual is having a vascular disease. So, right? One more point. Now, apart from that, the individual is also the hypertensive. And if hypertension is there, according to your CHA2DS2 VAS scoring system, you need to give a score of 1 point. Okay. Next, the another important thing is, right? The another important thing is, glucose is normal, cholesterol is 159, right? Now, what will you give? So, how much is the total score? 3. When the total score is 3, you need to give the anticoagulant, that is warfarin, should be given. Now, whenever you are giving this oral anticoagulants, you also need to assess the risk of bleeding, right? You need to assess the risk of bleeding. So, for assessment of the risk of bleeding, we have a scoring system called as the Hess-Bled score. What does this Hess-Bled score stands for? H stands for hypertension. If the individual is having uncontrolled blood pressure, you need to give a score of 1. and A stands for abnormal renal and as well as liver function test, right? You give a score of 1, or if both abnormal renal and liver function tests are there, then you give a score of 2. And if the individual is having stroke, give a score of 1. Bleeding tendency or predisposition is there, give a score of 1. L stands for labile INR, right? If the INR is labile, give a score of 1. And age of the individual is more than 65 years, then give a score of 1. And drug history. So concomitant aspirin or NSAIDs or alcohol, if it is there, give a score of 1. So how much is the total score? The total score is 9. So the point is that more is the score, greater is the chance of bleeding with the anticoagulants. Okay, so that is about your Hess blood score. Now coming to the investigations in these individuals. See, the investigations, the first line investigation will be the 2D echo, right? But what will be the definitive investigation? The definitive investigation which is required is cardiac catheterization. Right, cardiac catheterization. Okay, that will be the definitive investigation. And the other investigations are ECG and as well as the chest X-ray. So these are the investigations which are required for the diagnosis of mitral stenosis. Now if you see the ECG first. So the question is, a 32-year-old woman attends her general practitioner for routine medical examination and is noted to have mid-diastolic murmur with an opening snap. Her blood pressure is 118 by 71 millimeters of mercury and pulse is regular at 66 beats per minute. She is entirely asymptomatic and chest X-ray has straight left heart border. ECG is suggestive of, right? So 1, 2, 3, 4. So, right, which will be the ECG which is suggestive of the mitral stenosis. So, right, and actually the ECGs which have been given here, right, they are little with the smaller images, but the answer is 1. I will show you the image 1 in a bigger format. Yes, so this is the ECG suggestive of mitral stenosis. First I will tell you the findings, right, then I will show it in the ECG also. So in mitral stenosis you have number 1 P mitral, right, P mitral, where the P wave it is of M shape, right, where the P wave it is of M shape. Okay, next, then followed by that, if you take the duration of the P wave, right, if you take the duration of the P wave, it will be more than 120 milliseconds. Right, it will be more than 120 milliseconds. So that will be the duration of the P wave. So you can make out here, this is lead to is considered as a rhythm strip, right? So this is the P wave and it is of M shape. Okay, so this is how the P wave will be. Right, this is how the P wave will be. Okay, so now the distance, right, or the duration between the two humps, it should be, right, it should be more than or equal to 40 milliseconds. And this total duration should be more than 120 milliseconds. So this we call it as the P mitral, which is seen in patients with the mitral stenosis. Okay, next. Now after having discussed about the ECG in patients with mitral stenosis, let me discuss the chest X-ray. So first I'll tell you the findings and then I'll show you the X-ray picture as well. So if you take the left heart border, right, the left heart border, it is straight, and the next important, there will be prominence of the main pulmonary artery. right? There will be prominence of the main pulmonary artery, and there will be also dilatation of upper lobe pulmonary veins. And why is that there will be dilatation of the upper lobe pulmonary veins? That is due to increase in the pulmonary venous pressure. And there will be also Kerley B lines. And this Kerley B lines, they are mainly due to the presence of the interstitial edema. Right, that is due to interstitial edema. Okay, then if you take the esophagus, when the left atrium is enlarged, if there is giant left atrium, there will be backward displacement of the esophagus. Right, there will be backward displacement of the esophagus. Okay, so that is about, right, so that is about the chest x-ray picture in patients with the mitral stenosis. Let me show you the x-ray. So this will be the chest x-ray. See, if this is the normal left atrial border, right, this will be the normal left atrial border. So you can see that here, this will be the aortic knuckle, right, which is formed by your aortic arch. So in mitral stenosis, what will happen? There will be straightening of the left heart border. Right, there will be straight left heart border. And this particular straight left heart border is due to left atrial enlargement, right, and even the aortic knuckle will be a small aortic knuckle. Okay, and that is the reason why you will have a straight left heart border. Then followed by that, you take the pulmonary artery. So you have a prominent pulmonary artery. So why is that you will have a prominent pulmonary artery? That is because of the pulmonary hypertension. And another very important, the X-ray finding is the double density sign. You see, this is the left atrium and this is the right atrium. Okay, so this we call it as the double density sign. And this particular double density sign, right, and that is again due to, right, that is again due to left atrial enlargement. And this double density sign, it is seen on the frontal chest radiograph in the presence of the left atrial enlargement and occurs when the right side of the left atrium pushes behind the right cardiac shadow, indenting the lung and forming its own distinct silhouette. Basically, the left atrium, it is in the retrosternal area in a normal individual. But in patients with mitral stenosis, what will happen is there will be left atrial enlargement. So, in the right parasternal area, you will observe two shadows. Right? In the right parasternal area, you will observe two shadows. Right? And what are these two shadows? One is your left atrium and the other one is the right atrium. Okay? Right. Then what will be the 2D echo finding? So the 2D echo finding is that the individual will have the hockey stick appearance, right? And why is this? You can observe that this is the hockey stick. And why is this particular hockey stick appearance? That is due to restricted anterior mitral valve leaflet. Right, that is due to restricted anterior mitral valve leaflet movement is the one which is responsible for or which will give you the hockey stick appearance in the 2D echo. So, in the 2D echo, what all you need to make out? Right, one is the valve area. So, in mild mitral stenosis, the area will be around 1.5 to 2 centimeters square. Whereas in moderate mitral stenosis, it is around 1 to 1.5 centimeters square. And in severe mitral stenosis, the area will be less than 1 centimeter square. And you take the gradient across the mitral valve. In mild mitral stenosis, the gradient is less than 5 millimeters of mercury. In moderate mitral stenosis, the gradient is 5 to 10 millimeters of mercury, and in severe mitral stenosis, the gradient will be more than 10 millimeters of mercury. Whereas if you observe the pulmonary artery pressure, in mild mitral stenosis, the pulmonary artery pressure will be less than 30 millimeters of mercury, whereas in moderate mitral stenosis, it is around 30 to 50 millimeters of mercury, and in severe pulmonary artery hypertension, it is more than 50 millimeters of mercury. So that will be the 2D echo finding in patients with the mitral stenosis. Now, after having discussed about the investigations, let me discuss in detail about the treatment of mitral stenosis. So, let me discuss the treatment of the mitral stenosis. So, in the treatment aspect, right, as we have discussed in the etiology, the most common cause will be the rheumatic heart disease, and this rheumatic heart disease, it is a recurrent disorder or it's a recurrent disease. So, you need to give the penicillin prophylaxis if the etiology of mitral stenosis, if it is secondary to the rheumatic heart disease. And this penicillin prophylaxis, it should be against group A beta hemolytic streptococci. Group A beta hemolytic streptococci. Okay. So, and what is that penicillin we give in these individuals is, we give injection benzathine penicillin. Right, we give injection benzathine penicillin. Okay, that is for secondary prevention of the rheumatic fever. Okay, now this benzathine penicillin, it has to be given deep IM. And what should be the dosage of this benzathine penicillin? It should be 1.2 million units, and it has to be given every 21 days. Right, this has to be given every 21 days. So that is about the dosage of the injection benzathine penicillin. And if the weight of the individual is less than 27 kgs, then the dosage is 0.6 million units. Okay, and that has to be given every 21 days. Right, and the route of administration will be the intramuscular route of administration. Now, what should be the duration of prophylaxis, right? How long you give this particular prophylaxis? So, if the individual, it all depends upon the underlying clinical scenario of the individual. If the individual has rheumatic fever without carditis, then in such case, you need to give this prophylaxis for 5 years. After the last attack, right, it has to be given for 5 years after the last attack, or you need to give up to 21 years of age. Whichever is longer. Now, what do you mean by that? Whichever is longer. See, for suppose, if the age of the individual is around 19 years and the individual have developed rheumatic heart disease and mitral stenosis, you should not give it up to 21 years, right? If the individual has acquired rheumatic fever and mitral stenosis at the age of 19 years, you have to give the benzathine penicillin prophylaxis for 5 years after the last attack. That is, from 19 years, you have to give it up to 24 years. Okay. Now, for suppose, if the individual had developed rheumatic fever at the age of 14 years, then in such case, don't give for 5 years and then stop. You have to give from 14 years up to 21 years, because that will be the longest period. So, whichever is longer, you have to give. For suppose, rheumatic fever with carditis, but no residual valvular disease. right? No residual valvular heart disease. Then you need to give benzathine penicillin for 10 years, right? You have to give it for 10 years after the last attack, right? Or you have to give up to 21 years of age. Right? You have to give up to 21 years of age, whichever is longer. For suppose if the individual is having rheumatic fever with persistent valvular heart disease, in such case you have to give benzathine penicillin for 10 years after the last attack, right? Or you have to give up to 40 years of age, whichever is longer. But in certain scenarios, we give this benzathine prophylaxis lifelong. So that is about the benzathine penicillin prophylaxis if the mitral stenosis, if it is secondary to rheumatic heart disease. Then coming to your infective endocarditis prophylaxis. See, recommendations for infective endocarditis prophylaxis are similar to those for other valve lesions, and they are restricted to patients at a high risk for complications from infection. So, in high risk patients, this infective endocarditis prophylaxis has to be given. Okay. So, what will be that infective endocarditis prophylaxis? We need to give vancomycin and as well as the ceftriaxone. Okay. And it also has to be given in those individuals or in those patients with history of infective endocarditis. Right, with history of infective endocarditis. So these are the group of individuals with mitral stenosis where the infective endocarditis prophylaxis has to be given. Next, followed by that, in patients with mitral stenosis who are symptomatic, right? What do you mean by the symptoms? These individuals, they'll have dyspnea. And why is that? That is due to pulmonary edema or the interstitial edema. So in them, you need to do restriction of the sodium intake, and you need to give small doses of the oral diuretics. This will be the treatment for the symptomatic individuals. And then finally, treatment of the atrial fibrillation. See, treatment of atrial fibrillation, right? We have three groups of drugs that we need to give in these individuals. That includes, we need to give the drugs to control the heart rate. You need to give the drugs to control the rhythm, okay, and you need to give the drugs to prevent the coagulation. Because in these individuals, there is thrombus formation, and this particular thrombus will shower an emboli whenever it is dislodged. So, what are the drugs that you will give to control the heart rate? We give beta blockers, right? And then non-dihydropyridine, right? Non-dihydropyridine calcium channel blockers. What are the examples for that? Verapamil and diltiazem. Right, verapamil and as well as the diltiazem. Okay, so these are the calcium channel blockers, and we have one more drug which will control the heart rate, that will be digoxin. Right, that will be digoxin. So these are the drugs which will control the heart rate: beta blockers, non-dihydropyridine calcium channel blockers, and as well as the digoxin. They will reduce or they will slow the ventricular rate of patients with atrial fibrillation. Now, to control the rhythm, right? So the drugs which are used to control the rhythm in patients with the atrial fibrillation is, we give amiodarone, right? And another important drug is ibutylide. Okay, so these are the drugs which are given to control the rhythm within the individual. Okay, now the anticoagulants. So either you need to give antiplatelets or you need to give the anticoagulants. Now what is the purpose? So based on which parameter we give these anticoagulants or antiplatelets is just now we have discussed, that is CHA2DS2 VAS scoring system. And if CHA2DS2 VAS scoring system, if the score is 2, you need to give oral anticoagulants, and if the score is 1, you need to give either antiplatelets or anticoagulants, and if the score is 0, then don't give any antiplatelet, or you can give any antiplatelet. Either of these you can follow if the score is 0. Then how to treat the mitral stenosis in pregnancy? See, pregnancy and it is associated with increase in stroke volume and increase in heart rate, results in increased transmitral pressure gradient and may precipitate the symptoms. So in pregnancy there is increase in the heart rate, and at the same time there is also increase in the stroke volume. So whenever there is increase in the heart rate, right, whenever there is increase in the heart rate, what will happen? The diastolic filling time will be decreased. Right, the diastolic filling time will be decreased. So when the diastolic filling time is decreased, what will happen to your transmitral pressure gradient? There will be increase in transmitral pressure gradient, right? There will be increase in the transmitral pressure gradient, and because of increase in transmitral pressure gradient, that will precipitate the symptoms. Right, that will precipitate the symptoms in individuals with the mitral stenosis. Okay, so in particular towards the end of the pregnancy, the cardiac output continues to be maintained by an increase in heart rate, increase in mitral gradient by shortening the diastolic filling time. Okay, next, followed by that, patients with moderate to severe mitral stenosis should have the condition corrected prior to becoming pregnant if possible. Okay, so in individuals, right, or in females with moderate to severe mitral stenosis, right, the abnormality has to be corrected so that the pregnancy, the symptoms will not get precipitated. And for suppose if a pregnant female, right, if suppose, so in individuals with moderate to severe mitral stenosis, the disorder has to be corrected before conceiving. For suppose the pregnant patient who becomes symptomatic, they can also undergo successful surgery. Okay, so pregnant patient who becomes symptomatic, they can also undergo, right, they can also undergo the successful surgery, and this surgery, it is preferred in third trimester. Right, this particular surgery, it is preferred in third trimester. Okay, and what will be the treatment of choice particularly in pregnant females? That will be balloon valvuloplasty, right? So okay, so balloon valvuloplasty, that will be the treatment of choice if echocardiographic valve score is low enough. Okay, next, then followed by that, you take in a non-pregnant mitral stenosis, what are the indications for intervention? So in a non-pregnant individuals with mitral stenosis, Indications for intervention, it focuses on the symptoms such as episodes of pulmonary edema, right? It depends upon the episodes of pulmonary edema. That means, in spite of medical management, if the individual is continuously being symptomatic, the individual is having the episodes of pulmonary edema, that is the point when you need to do an intervention in mitral stenosis. Next, a decline in exercise capacity, right? A decline in exercise capacity, or any evidence of severe pulmonary hypertension, right? Any evidence of severe pulmonary hypertension where the pulmonary artery pressure will be more than, right? Pulmonary artery pressure will be more than 50 millimeters of mercury, right? So these are some of the indications that you need to do the intervention, okay? And some experts believe that the presence of atrial fibrillation should also be considered for an intervention, but like that is a little dicey scenario whether to do or not to do. And most interventions are not pursued until the patient is symptomatic. Only in symptomatic mitral stenosis you need to do the intervention. And even though if the individual is having severe mitral stenosis, but if the individual is asymptomatic, you can wait for the intervention, okay? Next, then followed by that, what is the intervention which are available and which is preferable? Let me explain. So we have two methods of intervention. One is open mitral commissurotomy versus the percutaneous balloon valvuloplasty. So this open mitral commissurotomy, now it is rarely performed. Right, so this is rarely performed and has given way to percutaneous balloon valvuloplasty. Right, so this is now rarely performed. So what is being performed in the recent days is percutaneous balloon valvuloplasty. Okay, so 10-year follow-up data comparing surgery to balloon valvuloplasty suggests no real difference in outcome between the two modalities. Okay, and in open mitral commissurotomy, there will be open heart type of surgery, right? You will cut open the chest, reach the mitral valve, take out the mitral valve and put the prosthetic mitral valve. But in case of percutaneous balloon valvuloplasty, right, it is through the catheter, right? And the catheter is passed through the femoral vein, right? The catheter containing the balloon is passed through the femoral vein and we reach up to the level of the right atrium, puncture the interatrial septum and reach the mitral valve and open the we will open the mitral valve with the help of a balloon. Okay. Now see, what about the replacement? Replacement of the valve is indicated when combined stenosis and regurgitation are present. So when is that valve replacement has to be done? Valve replacement has to be done if the individual is having mitral stenosis with moderate to severe mitral regurgitation. Okay, so in moderate to severe mitral regurgitation, we do this particular valve replacement, or valve replacement is required, right? Next, followed by that, you take the PBMV, that is percutaneous balloon mitral valvuloplasty. This PBMV, it has a very low mortality rate and as well as low morbidity. So compared to your open mitral commissurotomy, they have they have low mortality and as well as the low morbidity, right? And operative mortality rates are as low as only 1 to 3%. And repeat balloon valvuloplasty can be done if the morphology of the valve remains suitable. Okay, so the PBMV is usually done only if the valves are pliable. Only if the valves are pliable, then we can do this particular PBMV. Then what will be the indications for mitral valve replacement, right? Indications for mitral valve replacement. So, number one, calcific mitral stenosis. Right. See, this calcific mitral stenosis, let me tell you, you cannot do PBMV, right? There can be rupture of the valve if you do PBMV for calcific mitral stenosis. And the another scenario is mitral stenosis with moderate to severe mitral regurgitation. You need to do the mitral valve replacement, right? So, in a scenario of moderate to severe mitral regurgitation, if you do a PBMV, you know, there can be precipitation of the mitral regurgitation. So, you should not do, right? Then, followed by that, the overall 10-year survival of surgical survivors is 70%, okay? So, how much is your 10-year survival rate? Right, 10-year survival rate is up to 70%, okay? And long-term prognosis is worse in patients more than 65 years of age, right? And in those individuals who have developed pulmonary hypertension and right ventricular dysfunction, in those individuals also they have a very poor outcome, okay? So, in individuals with pulmonary hypertension and in individuals with right ventricular hypertrophy, they have, right, they have the poor outcome. So, this will be the indications for the mitral valve replacement. Now, you need to know what will be the complications of mechanical mitral prosthetic valves, right? What will be the complications of mechanical mitral prosthetic valves? They include, see, these individuals, they are more prone for thrombosis, right? They are more prone for thrombosis than compared to that of your PBMV, right? Now, this thrombosis, it is more common in the prosthetic, right? It is more common in the prosthetic mitral valve than compared to that of prosthetic aortic valve, right? So, the thrombosis, it is more common over the prosthetic mitral valve than compared to that of the prosthetic aortic valve. And what should be the recommended INR in individuals who are on the, or who are having this prosthetic valve? They have to be put on the oral anticoagulant, and that will be your warfarin, right? And what should be the INR that has to be monitored? The INR that has to be monitored should be in between 2 to 3 when the patient is on this particular warfarin, okay? Next, these individuals with mechanical prosthetic valve, there is chance of development of infective endocarditis, right? There is chance of development of infective endocarditis. So, endocarditis prophylaxis is indicated for patients with prosthetic heart valves. Right, so endocarditis prophylaxis is indicated for patients with prosthetic heart valves, okay? But it is not indicated in native valve disease, but prosthetic heart valves, definitely the infective endocarditis prophylaxis has to be given. Next, then followed by that, I said you now that percutaneous balloon mitral valvuloplasty, that is PBMV, is now the treatment of choice for many symptomatic patients with moderate to severe mitral stenosis. And this PBMV, it may also be recommended for asymptomatic patients with moderate or severe mitral stenosis who have pulmonary artery pressures more than 50 millimeters of mercury at rest or more than 60 millimeters of mercury with exercise. Usually, mitral valve replacement should not be done unless the individual is symptomatic. But this PBMV, it can be done in individuals who are asymptomatic with moderate to severe mitral stenosis right, with moderate to severe mitral stenosis, in whom the pulmonary artery pressure, it is more than 50 millimeters of mercury at rest, or in those individuals who have pulmonary artery pressure more than 60 millimeters of mercury with exercise. Okay, so this will be the indications of PBMV even though if the individual is asymptomatic. Okay, and this PBMV is only recommended for patients with favorable morphology in the absence of left atrial thrombus. So the PBMV should be done only if the valves are pliable valve, right, and there should be no thrombus in the left atrium, right, there should not be any thrombus in the left atrium, and the individual should not have moderate to severe mitral regurgitation. If the individual has moderate to severe mitral regurgitation, then PBMV should not be done. Okay, so these will be like absolute contraindications for PBMV. What are those? Number one, moderate to severe mitral regurgitation. Calcific mitral stenosis and the presence of atrial thrombus, right, the presence of atrial thrombus secondary to atrial fibrillation. Okay, so these are the absolute contraindications. Then there are also certain relative contraindications, that is presence of thrombus which is localized to the left atrial appendage and presence of unilateral commissural calcifications. These are the relative contraindications. Now, after having discussed about the open heart or open mitral commissurotomy and as well as closed, right, closed is nothing but your PBMV, that is percutaneous balloon mitral valvuloplasty. We have one more modality of the treatment, that is the maze procedure. See, a maze procedure may be done at the same time to reduce the recurrent atrial arrhythmias. So, whenever you are doing open mitral commissurotomy, that is the point when you need to do this maze procedure, right? And what is the purpose of this maze procedure? That is mainly to reduce the recurrent atrial arrhythmias. Right, that is mainly to reduce the recurrent atrial arrhythmias. So, now what is that we will do in the maze procedure? It involves a number of endocardial incisions across the right and as well as the left atria. So, number of multiple endocardial incisions, right, across the right atria and as well as the left atria. So whenever you give a number of endocardial incisions across the right and left atria, that will disrupt the electrical activity that sustains atrial arrhythmias. So these incisions will disrupt abnormal electrical activity. Right, this will disrupt abnormal electrical activity that sustains the atrial arrhythmias. So that is the purpose of doing this particular maze procedure. Now, let me just summarize the treatment depending upon the clinical scenario of the individual. So, now in case of rheumatic mitral stenosis, you need to divide the categories, right? So this is the new classification or the new guidelines, right, wherein If you say very severe mitral stenosis, the valve area should be less than or equal to 1 centimeter square. Right, in the beginning of the session, I said like severe mitral stenosis to be less than 1 centimeter square and very severe to be less than 0.8 centimeter square. Right, so this is a table which has been released recently, wherein very severe is considered as less than 1 centimeter square. Okay, right, so to avoid the confusion, let me tell you, severe mitral stenosis means it should be less than 1 centimeter square. Okay, and not only the valve area we take into criteria, we also take the gradient and as well as the T half. What is that? I'll tell you. So mitral valve area less than 1 centimeter square, and if the gradient across the mitral valve is more than 10 millimeters of mercury and T half, that is half time, more than or equal to 220 milliseconds. What do you mean by the word T half? That is time taken for half of the blood to move from the left atrium to the left ventricle. If it is more than or equal to 220 milliseconds, that means it's a very severe mitral stenosis. Now you need to know whether the individual is asymptomatic or symptomatic. For suppose if the individual is asymptomatic and the individual has favorable valve morphology, no LA clot, right, and there is no or mild MR, right, if all of these are there, then PBMV can be done. If any of this is not there and if the individual is asymptomatic, then periodic monitoring is done. And for suppose an individual with very severe MS if symptomatic and if everything is fine, favorable valve morphology is there, there is no LA clot, there is no MR or mild MR, then you need to do PBMV. For suppose if either of these, right, the valve is calcified, right, and there is presence of the LA clot, there is moderate to severe MR, then in this scenario, these individuals, they are considered to be under high surgical risk, and these patients, they have to undergo mitral valve replacement. They have to undergo mitral valve replacement. Okay. Now, coming to the severe MS. So now at this point, we have a confusion now. So, very severe, we take it under less than or equal to 1 centimeter square, whereas this we will make a small correction. It is the moderate mitral stenosis. Okay, so moderate mitral stenosis, that area is around 1 to 1.5 centimeter square and the gradient is more than 5 millimeters of mercury and half time T half is more than or equal to 150 milliseconds. Then if the individual is symptomatic, we follow the same. Okay, but if the individual is having new onset atrial fibrillation and valves are pliable, there is no LA clot, there is no or mild MR, if all of these are there, then these individuals have to undergo percutaneous balloon mitral valvuloplasty, that is PBMV, right? If any of these are not there, right, nothing is there, then periodic monitoring has to be done, and at one point of time, these individuals, they will be requiring the mitral valve replacement. And if they are asymptomatic, like periodic monitoring has to be done. And if it is like progressive mitral stenosis, where the valve area gradient is less than or equal to 5 and the T half is less than 150. In such scenario, if the individual is symptomatic, you need to calculate the pulmonary capillary wedge pressure. If the pulmonary capillary wedge pressure is more than 25 millimeters of mercury, right, and if the valve area and if the valve is a pliable valve, no LA clot, no or mild MR, then PBMV has to be done. Okay, but if the individual is like symptomatic, but the pulmonary capillary wedge pressure is less than 25 millimeters of mercury, then periodic monitoring has to be done. Okay, so that is about the treatment of the rheumatic mitral stenosis. Now let me tell you the essentials of diagnosis, right, that is summary. So what will be the clinical presentation of these patients with mitral stenosis? Fatigue, that is due to decrease in cardiac output, exertional dyspnea, that is due to interstitial or pulmonary edema, and orthopnea is also again due to pulmonary edema. And symptoms often precipitated by onset of atrial fibrillation or pregnancy. These are the two precipitating factors for mitral stenosis for the development of symptoms. And interventions indicated for symptoms, atrial fibrillation or evidence of pulmonary hypertension. And most symptomatic patients, they have the mitral valve area less than 1.5 centimeters square. So this is about the gist of the mitral stenosis. Now let me discuss some of the important multiple choice questions on the topic of mitral stenosis. So the first multiple choice question is, mitral valve replacement is recommended in patients with moderate mitral stenosis in NYHA class 2, moderate mitral stenosis in NYHA class 3, severe mitral stenosis in NYHA class 2, severe mitral stenosis in NYHA class 3. So definitely it is NYHA class 3 who requires the mitral valve replacement, and that too in patients with severe mitral stenosis. So severe mitral stenosis in NYHA class 3, they require the mitral valve replacement. Next, which of the following is the least common cause of the true mitral valve stenosis? Cor Triatrium, rheumatic fever, SLE, and congenital mitral stenosis. So the answer is the Cor Triatrium, right? So where you have the presence of a fibrous band within the left atrium, and left atrium is divided into two chambers here. Okay. Next, so and it is the least common cause. Next question is, following is true regarding the opening snap. It's a high pitched diastolic sound. It is due to opening of stenosed aortic valve. It indicates the pulmonary arterial hypertension, and it precedes the aortic component of the second heart sound. So let me tell you, it is a high pitched diastolic sound, right? It is a high pitched sharp diastolic sound, right? And it is not due to opening of stenosed aortic valve, it is due to opening of stenosed mitral valve. So if suppose, what is the sound that will be produced due to opening of stenosed aortic valve? That will be click. Okay, and this will be a systolic sound. Right, this will be a systolic sound. And it indicates the pulmonary arterial hypertension? No, right? In all the cases of your mitral stenosis, you have the presence of the opening snap, right? And your pulmonary arterial hypertension can be seen in any forms of your mitral stenosis, right? Your opening snap and pulmonary arterial hypertension has no relation, okay? And it precedes the aortic component of second heart sound? No, it succeeds, right? It succeeds the aortic component of the second heart sound, okay? Next question. Mid-diastolic murmur with pre-systolic accentuation is typically seen in mitral stenosis, mitral regurgitation, aortic stenosis, and mitral valve prolapse. So mid-diastolic murmur with pre-systolic accentuation is seen in patients with the mitral stenosis. Whereas in mitral regurgitation, you have a pansystolic murmur which will be radiating to the axilla. And in aortic stenosis, you have the presence of the ejection systolic murmur. And in mitral valve prolapse, right, in mitral valve prolapse, you have the presence of a mid-systolic click, right, you have the presence of a mid-systolic click with late systolic murmur. Okay, so that is what you will observe in the mitral valve prolapse. Next question. Severity of the mitral stenosis is assessed by loud opening snap, length of the murmur, loud S1, splitting of the second heart sound. So the severity of the mitral stenosis, let me tell you, it is decided by the duration of the murmur, and it is not decided by the intensity of the murmur, it is decided by the duration of the murmur. And another important parameter is the A to OS gap. Right, so these are the two parameters which will decide the severity of mitral stenosis. And mitral stenosis is associated with right ventricular hypertrophy, left ventricular hypertrophy, left axis deviation, presence of the QRS complex. Mitral stenosis, it is associated with the right ventricular hypertrophy. So why is that? This will be there secondary to the development of pulmonary arterial hypertension. Okay, so secondary to the development of pulmonary arterial hypertension, right, the individual will develop right ventricular hypertrophy. Why? Because there will be increased afterload on the right ventricle, thereby there will be right ventricular hypertrophy. Next, following is true regarding the opening snap. It is a high pitched diastolic sound. This we have already discussed. Yeah, severity if mitral stenosis is judged by, or severity of, not if, severity of mitral stenosis is judged by loud S1, S2 OS gap, prolonged diastolic murmur, presence of S3 and as well as S4. So the severity, it is decided by your S2 OS gap and as well as the prolonged mid-diastolic murmur. Okay, next question. Absence of the loud first start sound in mitral stenosis indicates all except. The answer is mild mitral stenosis. Okay, so in case of calcified mitral valves, you will have soft S1, you will not have loud S1. And in aortic regurgitation, you will neither have loud S1, you will nor have soft S1. And in first degree heart block, you will have prolonged PR interval and you will have soft S1. Whereas in mild mitral stenosis, you have the presence of loud S1. So what is the question asked? The question asked is, absence of loud first start sound in mitral stenosis indicates all except means mitral stenosis. So in mild mitral stenosis, you have the presence of loud S1. Next question. Double density sign in mitral stenosis is a sign of enlargement of, right? It is a sign of enlargement of the left atrium. That is what is your double density sign. Next. All of the following may be seen as severity of the mitral stenosis increases except pulsatile lever, atrial fibrillation, opening snap delayed from S2, length of the murmur is prolonged. So, pulsatile lever will be there in severe mitral stenosis and that is due to, or that is secondary to, right heart failure in patients with the mitral stenosis. Right, in patients with mitral stenosis, they develop pulmonary hypertension, and because of pulmonary hypertension, they can develop right heart failure, and wherein they can develop pulsatile lever, right? And in severe mitral stenosis, there is also development of the atrial fibrillation, and even the length of the murmur is also prolonged. But opening snap is not delayed from S2, right? It will be very close to S2. Okay, next. Which clinical sign, right? Which clinical sign is suggestive of elevated pulmonary wedge pressure in mitral stenosis? The options are loud OS, loud S1, mid-diastolic murmur, short A2 OS interval, right? So elevated pulmonary capillary wedge pressure means it should be a severe mitral stenosis. So the one which is suggestive of severe mitral stenosis is short A2 OS interval. Okay, next question. Which is the valvular lesion being repaired in this 20-year-old man with malar flush? Mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. See, what is that you are observing here is the presence of the mitral valve being repaired by your PBMV, percutaneous balloon mitral valvotomy. So, the valvular lesion which is being repaired by your PBMV will be your mitral stenosis. Okay, so the answer is A. Next question. Absolute contraindications for PBMV include all of the following except presence of pulmonary arterial hypertension, left atrial mobile thrombus, severe mitral regurgitation, bilateral commissural calcification. So remember, presence of pulmonary hypertension, right? It is not a contraindication for PBMV. If there is pulmonary hypertension, you have to do PBMV, right? You have to do PBMV, right? You can do PBMV, right? And if the PBMV is done, the pulmonary hypertension of your mitral stenosis will get reduced. And if there is left atrial thrombus, yes, it's an absolute contraindication. If severe mitral regurgitation is there, yes, it's an absolute contraindication. And if there is bilateral commissural calcification, that is also an absolute contraindication. So, presence of pulmonary hypertension, let me tell you, it is not a contraindication for PBMV. Next, hockey stick appearance in echocardiography is a feature of mitral stenosis, mitral regurgitation, aortic stenosis and aortic regurgitation. So, the answer is the mitral stenosis. And this hockey stick appearance in echocardiography is due to restricted anterior mitral leaflet. Right, it is due to restricted anterior mitral leaflet. So that is what is responsible for hockey stick appearance in echocardiography. Okay, next, mitral valve replacement is recommended in patients with moderate mitral stenosis in NYHA class 2, moderate mitral stenosis in NYHA class 3, severe mitral stenosis in NYHA class 2, severe mitral stenosis in NYHA class 3. So I hope like we have discussed the same question previously, that is severe mitral stenosis in NYHA class 3. Next, which procedure is being done in this image shown? Percutaneous mitral balloon valvotomy, valvuloplasty, valve repair, percutaneous coronary intervention. See, what is being done here is percutaneous mitral balloon valvotomy. Otomy means opening. So what is that you are doing? With the help of a balloon, you are trying to open this stenosed valve, right? So it is a percutaneous mitral balloon valvotomy. Okay, next question. A lady presents with grade 3 dyspnea. She has severe mitral stenosis with atrial fibrillation. Along with increased ventricular rate, clots in the left atrium are seen. Which of the following should not be done? The options are diltiazem to reduce the heart rate, warfarin therapy, open mitral commissurotomy and removal of the clot, and cardioversion with percutaneous balloon mitral valvotomy. So just now we were discussing that there are certain contraindications for your PBMV, and one of the very important contraindication is the presence of clots. So if there is left atrial thrombus, cardioversion with PBMV should not be done, because this clot can get dislodged and the individual can have emboli, and that emboli will enter into the systemic circulation and any part of the body can get affected by that particular emboli. So that is the reason why cardioversion with PBMV should not be done in individuals who are having the LA clot. So these are some of the very important multiple choice questions on the topic of mitral stenosis. So with this, we will wind up the very important valvular heart disease, that is mitral stenosis. Thank you very much.